My name is Howard Fink. I'm a physician at the Minneapolis VA Medical Center. I'm going to talk for a few minutes about chronic kidney disease screening, addressing the question as to whether the population should be screened for chronic kidney disease. Recently completed an AHRQ systematic review and meta-analysis to investigate benefits and harms of chronic kidney disease screening, monitoring, and treatment. Based on this work, we looked initially for randomized controlled trials that compared chronic kidney disease screening of any type versus usual care, no screening, or any other intervention in any population and looking at the benefits and harms. There were no such studies. There was no direct randomized controlled trial evidence addressing the benefits and harms of chronic kidney disease screening. So in the absence of randomized controlled trial data that directly address whether screening improves outcomes or is associated with harms, we tried to look at whether different pieces of evidence could collectively address this question. So we tried to look at this piece by piece. It's clear that chronic kidney disease is associated with adverse outcomes. Prevalence of chronic kidney disease in the U.S. population is relatively high at about 14%, and that's increased in certain risk groups, including older adults, patients with diabetes, hypertension, and cardiovascular disease. There is a high use of creatinine testing in usual care, and so most people with a low GFR have that documented, but the use of albuminuria testing in usual care is relatively low, about a third of diabetics and much less in hypertensive patients and other populations. With regard to whether there's the treatment of chronic kidney disease patients might improve outcomes, in our systematic review we found that there are several treatments that patients with chronic kidney disease had improved outcomes. However, these benefits appeared to be limited to selected patient subgroups and, in most cases, were identified by post hoc analyses in which studies investigating that treatment were later analyzed. In most cases, the relative benefits of the treatment were no different in patients with and without chronic kidney disease. In addition, that patient group may have already had an indication for the treatment, so knowledge that the patient had chronic kidney disease probably would not have made a difference in a decision regarding whether or not to treat. The next piece of indirect evidence that might help assess whether screening for chronic kidney disease is useful is whether it's associated with harms. And we didn't find any trials, any evidence regarding whether chronic kidney disease is associated with harms. Any screening potentially could, but we didn't find this evidence directly. Then with respect to the cost and feasibility, in our systematic review, cost was considered outside the scope. So I'm aware that there are a number of cost effectiveness analyses. These have generally concluded that screening the general population is not cost effective and that screening diabetics or hypertensives may be cost effective. So trying to put all this together, screening chronic kidney disease would be least likely to be of benefit in patients at low risk for chronic kidney disease complications, in populations for which there is not strong evidence that treatment of such patients with chronic kidney disease improves outcome. And we did not find evidence that patients with hypertension, in the absence of cardiovascular disease or diabetes, have improved outcomes. Chronic kidney disease screening is unlikely to be of benefit in the whole population. It may be of benefit in limited patient subgroups.